Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article number 23. Welcome to the Pain is Not the Only Problem podcast. Article 23, Pain is Not the Only Problem. Sagittality. Yes, Sagittality is a real thing. Thanks to Dr. Dean here. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction and clinically meaningful results, recommend a conservative non-surgical course of care to override pain instantly, and restore ADLs and patient confidence on the first visit at low cost. Dean 2006 offers us this radical idea: sagittal plane overuse syndrome, SPOUS, spouse. Sagittal plane overuse syndrome is defined by Dean as the chronic central activation of sagittal plane motor mechanisms to accomplish daily activities, resulting in soft and hard tissue injury and plastic changes, osseous changes, neural changes, and motor mapping changes that support primarily sagittal plane movement patterns. What are we talking about here with sagittal plane overuse syndrome? Everyday life actions can be expanded into several categories: daily activities, work duties, exercise and training, sports, hobbies, leisure, and family and personal care. These categories describe segments of the patient or athlete's day, each segment with its own demands on the patient's body. A daily history that embeds itself in the archived relationship of action meeting with demand. In a snapshot, these actions might include standing, sitting, walking, running, taking stairs, bending, reaching, reading, cleaning, dressing, grooming, eating, driving, cooking, sleeping. Activities that primarily occur in the sagittal plane of the head, neck, shoulder, hip, knees, spine, and ankles. Cardio exercise machines such as a treadmill, elliptical, the rower, stationary cycle, or a stair stepper engage only the sagittal plane of action. Gym exercise equipment is also designed primarily to engage in the sagittal plane of motion and commonly requires both limbs to act together. Arms push or pull together, legs push or pull together. This is not a common occurrence in everyday life. Considering daily activities combined with exercise, the sagittal plane is the most recruited plane of motion in the human body. The transverse plane and frontal planes contribute literally nothing to the patient-athlete's everyday actions and training, putting an enormous imbalance in all body recruitment. However, all three planes of motion, 4 if you include axial compression or ground force reaction, and 5 if you include distraction, are important to provide a variety to the human action experience. A spine that is only activated in the sagittal plane and minimally in rotation and lateral bending will literally be experiencing only 1/3 of its potential range of motion. This is a dangerous situation since a sagittal spine will not be able to activate effectively nor efficiently when it is required to also perform in rotation and lateral bending. It is important to clarify a specific point. Sagittal plane action is purely sagittal, but what we are interested in is sagittal plane action combined with rotation and lateral bending in the endless possible combination of multiple planes and multiple directions. It is naive to expect a sagittal spine to perform in planes of motion for which it has no experience, and this creates two problems. One, the motor relationship between the sagittal spine with rotation and lateral bending is undeveloped, and therefore injury is imminent. And 2, the proprioceptive relationship between central processing with rotation and lateral bending is undeveloped, and therefore, again, injury is imminent. Motor relationships and proprioception are learned. They are not intrinsic. Motor relationships rely on patterns that require repetition and practice. Motor patterns are sequences. If a component of the sequence is missing, there is no sequence, and therefore there is imminent strain, stress, and of course injury. Absent planes of motion break the sequence, and the outcome is always the same, a faulty motor pattern. Acutely, persistent sagittal action may cause annoying back pain, shoulder, and neck strain, or there may be no presenting symptoms, such as the case in subthreshold microtrauma, article number 17. This acute exacerbation might be termed sagittitis, or with pain, sagittalgia. With time, it is possible that the patient's body will deform into the sagittal plane, as demonstrated in upper and lower cross syndromes and acquired kyphosis. This chronic condition might be termed sagittosис. Don't pick on me. It is pertinent that the clinician evaluate the sagittality of the patient-athlete's everyday activities. If the clinician simply asks the patient if they get 30 minutes of daily activity, the clinician might be missing the possibility that the patient's low back pain might be largely due to an absence of mixed plane activity, since pain is not the only problem. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-culture willingness to strengthen medicine. Thank you.